So the Ken Vector National Thrombosis Seminars are monthly seminars that are hosted throughout the academic year, featuring state-of-the-art thrombosis and venous thromboembolism lectures presented by both Canadian and international experts. The video recording of this session will be available online after at the Ken Vector website. These seminars are self-approved for group learning activities, so with the maintenance of certification. Here is the planning committee. Sorry to introduce myself. I'm Jamil Abdul Rahman. I'm a thrombosis physician in Toronto. And today's talk is on post-thrombotic syndrome, from clinical insights to machine learning. Our speakers today are Dr. Arina Cate-Hoek. She's an associate professor of medicine and medical director of the Anticoagulation Clinic at Maastricht University Medical Center. Her research focuses on venous thromboembolism, particularly the diagnosis, treatment, and long-term complications of DVT, including post-thrombotic syndrome. She is internationally recognized for her work in thrombosis research and is actively involved in international collaborations and guideline development aimed at improving prevention, risk stratification, and outcomes after venous thromboembolism. And after Dr. Cate-Hoek, we'll have Dr. Arina Iding, who is an internal medicine resident and clinical research focused on thrombosis and vascular medicine. He completed his PhD at Maastricht University under the supervision of Professor Arina Cate-Hoek, studying long-term outcomes after DVT, particularly post-thrombotic syndrome. His work uses clinical data, biomarkers, and data-driven methods to better understand and to predict complications after DVT. So with that, I'll turn it over to our speakers. Thank you for being here today.
Well, thank you very much for this very kind introduction. I will start with a short introduction on the clinical aspects of post-thrombotic syndrome and the knowledge that we have gained so far. And Aaron will follow me and introducing you to our experiences with machine learning in this context. These are my disclosures. Next. I'm sure you're all very familiar with post-thrombotic syndrome, but just a short recap. Post-thrombotic syndrome is a common but chronic complication of deep vein thrombosis, which occurs in 20 to 50% of patients, with the highest risk in those with iliofemoral deep vein thrombosis. It incurs significant costs, both due to direct healthcare costs, due to treatment for instance, venous ulcerations, but also indirect costs due to work productivity loss. And last but not least, post-thrombotic syndrome reduces quality of life considerably. Next. The clinical manifestation of post-thrombotic syndrome is characterized by signs such as edema and skin changes, which is shown here in a very mild form, but it can also be more severe, with necrosis of the subcutaneous fatty tissue, impairing the skin perfusion and making the patient more vulnerable to venous ulceration. Patient experience symptoms such as heaviness, pain, itching, cramps, and paresthesia. And as said before, there is an impact on quality of life as shown in these histograms, which is differential with the severity of the disease, with also in more milder forms of PTS, a significant reduction of the quality of life. Next. The annual incidence of post-thrombotic syndrome in Europe, to just give you an idea, is 250,000 new cases diagnosed each year, of which 90,000 are moderate to severe. And if you look at the left-hand side, you'll see a graph which shows that post-thrombotic syndrome is really a disease very much associated with older age. You can see the steep increase in the incidence from the age of 70 to 74. And you also see in the colored bars the incidence in relation to the extent of the thrombosis. And in the green, you see the femoral popliteal deep vein thrombosis, and in yellow, the distal thrombosis, and in between, the iliofemoral deep vein thrombosis. Iliofemoral deep vein thrombosis, as shown in the right-hand side of the figure, has the highest risk of post-thrombotic syndrome, but in the incidence, it's lower than the femoral popliteal because femoral popliteal thrombosis is more common. So looking at the severity of the thrombosis, iliofemoral deep vein thrombosis is both at higher risk and it's more available. And if you look at the more distal deep vein thrombosis, you will see that even if it's distal DVT, still 20% of patients will get post-thrombotic syndrome, and about 4% will have a more severe form of post-thrombotic syndrome. Both age and extent of thrombosis, of course, are non-modifiable risk factors. Next. Obesity is a modifiable risk factor. And we see that obesity, defined as BMI greater than 30, is associated both with post-thrombotic syndrome, but also with chronic venous disease in general. And we see that in higher age, these two disease entities tend to overlap more. And although we know that obesity is a risk factor, it is present in all our current PTS risk score models. It is mainly ignored in clinical practice, and it's not part of preventive therapy at this moment, which is a pity. Next. If we look at the pathophysiology of post-thrombotic syndrome, we see that the key feature is venous hypertension, which is due to impaired thrombus resolution. And as thrombus resolution is essentially an inflammatory process, the continued inflammation in case of delayed thrombus resolution will give rise to vein wall remodeling and fibrosis, leading to valve damage with valvular reflux and also to venous outflow. Next. Both reflux and residual vein obstructions are independent risk factors for post-thrombotic syndrome. And we found in this sub-analysis of the CAVA trial in a population of patients with moderate to severe post-thrombotic syndrome that if these two risk factors occur together, the risks are even higher. It's sort of a synergistic effect. But also we noticed that there is a proportion of patients who do not have any obvious underlying problem, which highlights that other factors besides reflux or residual vein obstruction may lead to severe post-thrombotic syndrome. Next. Not so long ago, we introduced the triad of vascular damage, which shows that there is a cycle of events leading to vascular damage, and this is a perpetual cycle of events that, if not interrupted, it will go on and be more severe in the end. It all starts with obstruction of the vein, like in the acute deep vein thrombosis, with acute venous hypertension leading to endothelial dysfunction, giving rise to leukocyte extravasation and activation into the perivascular space, which will give a persistent inflammatory response leading to delayed thrombus resolution and excessive fibrosis of the vein wall, again resulting in residual vein occlusion, reflux, and venous hypertension, and so on and so forth. Next, thank you. And this shows the underlying biological processes that we have discovered so far. And it might not come as a surprise that both inflammation and coagulation are important underlying mechanisms, even as vein wall remodeling, but also endothelial perturbation leading to also upregulation of cell adhesion molecules. And maybe less well known is next that also metabolic risk factors could play a role, and especially the fatty tissue, leading to chronic low-grade inflammation and also post-thrombotic syndrome. So taking together all of these things, we have come a long way in identifying the major pathophysiological risk factors of post-thrombotic syndrome. But at this time, we're still not able to use this knowledge in clinical practice. Next. Our early clinical prediction for post-thrombotic syndrome in clinical practice is at this moment relatively simple, as well as underused. And I think maybe we should go and try and integrate all our knowledge into more sophisticated risk models and not look at population levels and associations of single variables or risk factors, but more to patient profiles. And I think machine learning techniques can help us. And I hope that Aaron will take us into our experiences with machine learning and maybe how we in the future can get to better risk prediction.
Yes, thank you. From here, after having this insight into post-traumatic syndrome and the individual risk factors, I want to take you with me to the perspective of patient clinical profiles, to have another perspective, indeed, of a more coherent risk profile of a patient. Because deep vein thrombosis, as you all may know, is a multifactorial disease, and we know that it's presenting in a heterogeneous population. And within this population, there might be distinct clinical profiles which differ in their clinical outcomes. And this has in recent years been studied by various research groups, including our own. And this is relevant because identifying these profiles could enable a more tailored management for these patients. And to help you understand these clinical profiles, I need to explain you something about cluster analysis. So cluster analysis is a form of unsupervised machine learning. And if you're less familiar with this, I'd recommend this narrative review by Rashidi et al. In the JTH, where they show an overview of machine learning. And here on the left, you see the more supervised machine learning, and on the right, unsupervised machine learning. And unsupervised machine learning distinguishes itself by being data-driven. So the algorithm does not know about the clinical outcomes, only about the patient's baseline characteristics. And clustering analysis is the most commonly used method of unsupervised learning. And specifically, we've been using hierarchical agglomerative clustering. And to help you understand that and to keep it simple, I have this figure on the right where you see patients represented by letters from A to F on a plot where the x-axis and y-axis represent patient's characteristic, in this instance, age and body mass index. And each patient has a different age, a different body mass index, but when we use this approach with this algorithm, we can hierarchically order them, where on the bottom, we see each patient, and with each step upward, we combine the two patients who are most similar together in one group until eventually all the patients are combined. And then to determine how many distinct groups we have, there are various indices available, 30 about, but what is commonly used and what we've also been using is to use a majority rule where the various indices are used and the number of groups that has the most indices will be selected. And in a previous study, we've performed this in a cohort of patients from our center, from Maastricht Medical Center. And these were consecutive patients with proximal deep vein thrombosis, more than 800 between 2004 and 2018. And we had extensive baseline characteristics of them. and using 23 baseline clinical characteristics, we did this clustering analysis, and this is visualized in this diagram. So this is called a dendrogram, and again, as we showed previously on the bottom, each point is one patient, and as we gradually go upward, patients are combined into groups until eventually at the top, all patients are combined. And the algorithm showed us here that there were 4 distinct groups within our population. And when we looked at their characteristics, we could describe them as these following groups. So younger females using estrogen therapy, patients with a cardiovascular risk profile, such as hypertension, hypercholesterolemia, and diabetes, patients with previous venous thromboembolism or known inherited thrombophilia, and lastly, a larger group with patients that were distinct from the other patients, but did not have a discriminating characteristic within the variables that we knew of them. And next, as we established these profiles of patients, we looked whether they differ in their clinical outcome. So here we show how the patients ranked. So here we have hazard ratios represented as bar plots. So relative to the first profile, profile 1, having a hazard ratio of 1, we saw that recurrent venous thromboembolism within 5 years follow-up was notably different, with the highest risk noticed in profile 2. And when we also looked at other outcomes, such as, most importantly here, post-thrombotic syndrome, but also arterial events, and also cancer diagnosis during follow-up, we saw a large difference between groups where, again, the lowest risk was observed in the younger females with estrogen therapy, and the highest risk was observed in these patients with a cardiovascular risk profile. Now, this seminar is about post-thrombotic syndrome, and when we looked at post-thrombotic syndrome, we saw that actually the highest risk was observed in patients with a previous VTE, which is not surprising given that a previous deep vein thrombosis is commonly known as a very high risk factor for developing post-thrombotic syndrome. But the risk on the other groups did not differ hugely, and this made us wonder whether post-thrombotic syndrome itself represents a heterogeneous syndrome, and whether just looking at the overall incidence is masking differences between these patient profiles. This is what we did in the study I want to present here. And we used there 2 perspectives in our method. So using data from the IDEAL DVT study, this was a non-inferiority trial with randomized duration of compression therapy, where specifically the specific details of this trial are not so relevant for the current study, because the duration of compression therapy was at least 6 months, and we'll be looking at outcomes at 6 months time point. So they did not differ based on randomization. And we had at this time point more than 800 patients, and we had variables about their clinical characteristics at baseline, where we had a look and did, again, hierarchical clustering of the patients into clinical profiles. And here it must be said, within this trial, we had less detailed variables than in the previously mentioned study. So we did not know, for example, the specific provoking risk factors, but still we had many variables available. And on the other hand, we had this second perspective, which we wanted to study, namely at the 6-month time point, looking at the Villalta score and its individual items, where we did variable clustering of the items of the Villalta score to look whether there are different manifestations of post-thrombotic syndrome. And what I mean by this will be more clear when I am showing you the results of this analysis. So in the results, first of all, looking at the clinical profiles, we again found 4 profiles of patients, where we found that profile 1 consisted of relatively younger patients with a provoked DVT, a majority being female. Profile 2 consisted of women with a high prevalence of joint pain. Profile 3 consisted of men with a mostly isolated popliteal DVT, so not very extensive DVT. And profile 4 consisted of older men with a cardiovascular risk profile, specifically a high prevalence of diabetes, and with the most extensive DVT. Now, when we looked overall at the post-thrombotic syndrome prevalence in these patients at 6 months, we actually didn't see any difference. So here, for example, we see that about all patients had about a 30% presence of post-thrombotic syndrome. And even if we looked at moderate severe post-thrombotic syndrome, we did not see significant differences between the groups. But then, of course, we had a further look at the manifestations of post-thrombotic syndrome. And I'm visualizing this in a vector diagram. And what's important to understand about this figure is that items which scored higher together within patients are represented more closely together. And what we saw, perhaps not so surprising, is that signs, so skin changes clustered mostly together, and the symptoms clustered together. The only exception being cough pain, which is traditionally categorized among the skin changes, but actually is also a semi-objective score, as the patient is asked to what extent they experience cough pain. And when we looked at the sign score and the symptom score, we actually saw a very low correlation between the sign score and the symptom score. And this surprised us, or at least me. And when looking through the literature, this has actually not been reported frequently. So I found, for example, one publication also reporting about this low correlation, but I think this is something that is not yet very much on the radar of everyone, that the correlation is quite low. And also interesting was that if we looked at a higher sign score or a higher symptom score, was that the symptom score was more often high. So for example, a score of 5 or higher was present in 14%, so more than double of the sign score. When we looked at the risk factors for these specific scores, we saw the following. So if we looked simply at the Villalta score on the right in gray, we saw actually that the only risk factor for the Villalta score was the body mass index. So a higher body mass index gave a higher risk of, gave a higher Villalta score. And we saw this as well, both for the sign score and the symptom score. That was both true for both scores. However, when we looked specifically at the sign score and the symptom score, we also saw opposite effects. So for age, we found that the sign score tended to be higher in patients with an older age, while the symptom score tended to be higher in patients with a younger age. And for sex, we saw that men had a higher sign score, while women had a higher symptom score. And furthermore, we saw that provoked DVT gave a higher symptom score, and femoral DVT was, and more extensive DVT was associated with a higher sign score. So here we really saw differences that would not have been observed if we only looked at the total score. Next, we had also a look at the presence of residual venous obstruction. So this was mentioned in the presentation before. It's evaluated based on an ultrasound exam of the leg, and the presence of residual venous obstruction was studied in most patients, in most centers of the study, and we found that the sign score was significantly associated with this residual venous obstruction, where there's an 18% increase of the odds ratio per point of the sign score. But to make this more tangible, if we looked in the upper quartile of sign scores, so a sign score of 3 or higher, we found a twofold higher odds ratio of residual venous obstruction. And in contrast, we did not find any association with the symptom score for residual venous obstruction. However, when we looked at quality of life, we did see that while the sign score was significantly associated with quality of life, the symptom score was noticeably more strongly associated with quality of life. And now I want to revisit these profiles. So I hope you still remember our 4 profiles that we found in this study. And now I want to look at this from the perspective of these manifestations of post-thrombotic syndrome, so the sign score and symptom score separately. And what we then found actually was that underlying there was a difference, and specifically mostly between profile 1, so the younger patient with provoked DVT, and profile 4, the older, mostly men with more extensive DVT and profile. So we found that the profile 1 had a lower sign score and a higher symptoms. Had a higher symptom score. I'm saying this again. The profile 1 had a high sign score, and profile 4 had. Well, okay. 1 second. Okay. So profile 1 had a low sign score and profile 4 had a high sign score, while oppositely, profile 1 had a high symptom score and profile 4 had a low symptom score. So we saw their opposite effect, while if we would look at the overall presence of post-thrombotic syndrome or the total Villalta score, we did not observe this. So I want to come to our conclusions, and starting very narrow on our study, we believe to conclude that the signs and the symptom score represent distinct manifestations of post-thrombotic syndrome. So using the total Villalta score as the risk of obscuring risk stratification for these patients. More broadly, we believe that using clinical profiles could provide a foundation for more tailored management of patients, but its translation to clinical practice will require a further step of validation, where we will use, for example, a decision rule to categorize patients within their profiles. And I can give an example of this if requested in the Q&A. And finally, to put it in a very broad perspective, I think that using unsupervised machine learning and specifically cluster analysis can give us a novel perspective on the patterns that we observe, and it can provide a framework for uncovering hidden patterns within the VTE population. I'd like to thank you for your attention, and I'm looking forward to the questions.
Thank you both for your presentation. So we'll open up to questions. If you want to type your questions in the Q&A section or the chat section, please go ahead and do that. So maybe to get things started, I have a question for Dr. ten Cate. I'm interested in your approach to compression stockings for prevention of post-thrombotic syndrome. I think it's still a bit controversial. So I'm wondering which patients do you use it in and for how long?
Good question. I didn't mention it because I was not talking on therapy today. Otherwise, I would definitely have mentioned it. And I think every patient is entitled to compression therapy, and I should start it as soon as possible within the first 48 hours, as we have shown that that will actually reduce residual vein obstruction and also post-thrombotic syndrome significantly. And taken together all the studies that have been done up until recently on compression therapy and deep vein thrombosis, we see that we can at least reduce the risk of post-thrombotic syndrome by 30%. So given the fact that compression stockings are not really a very expensive treatment, and they do not have a lot of not a lot of effects that are negative on your health, I would urge everybody to give your patient the benefit of compression when they have an acute vein thrombosis.
Okay, great. And would you use those in every patient or just with the more proximal DVTs? Like
No,
if they have a
all
distal DVT?
all patients yeah, are entitled to compression, as I showed in the beginning, with the incidences of post-thrombotic syndrome and also severe post-thrombotic syndrome. Also, the patients with more distal thrombosis were having risks up to 20% of having post-thrombotic syndrome and 4% for severe post-thrombotic syndrome. So if you can maybe reduce that by 30%, relatively, of course, then I think you should do this.
Perfect. Great. Thank you for that. And for Dr. Iding, question for you as well. So in your data, you didn't show correlation between the signs and the symptoms, and then in our different profiles, there was, I guess, discrepant results between the signs and the symptoms. Why do you think that was? Why are they so different?
Why the signs and symptoms are so distinct?
Mm-hmm.
Well, so the correlation indeed is quite low, and we see that if we look at patients, there's a noticeable amount of patients that have only signs or only symptoms, and this explains that. And we observed that a bit in the profiles as well. I think it's difficult to say why some patients would have signs and not experience symptoms. In clinical care, I do notice that this is sometimes the case, that patients don't experience that many symptoms despite having noticeable signs. And I think a limitation of that might be that we don't know on the longer term if there will still develop symptoms. And of course, what is always the case with post-thrombotic syndrome is that we don't know what other comorbidities are influencing the symptoms. If the symptoms are really derived from the post-thrombotic state, or that the symptoms are derived from other comorbidities or experiences. What stimulates us to think that there's really a difference between signs and symptoms is this analysis of residual venous obstruction, where we see that it has a strong association with the signs but not the symptoms. But I'm therefore definitely not saying that the symptoms don't have a pathophysiological background. But in this current study, we couldn't examine it further than only looking at residual venous obstruction. I think a limitation of that is, for example, that we didn't in this study have data on the presence of venous reflux. And in addition, there are other mechanisms such as reduced microvascular perfusion, which could also have a role. So this is something we would like to study in the future to understand more about what is the pathophysiology underlying these symptoms and why is it sometimes distinct from the signs.
Perfect. Thank you. Okay, great. And then one question for both of you. What are the big unanswered questions in post-thrombotic syndrome in terms of like pathophysiology, prevention, management? What are the big questions we still need to answer?
We have a couple of hours. There's many questions. I think because this is a very broad and complex disease entity. I showed we already know a lot of things, the biology but still we are scratching at the surface of the real problem. So I think I would not be able to just name just one thing. Maybe Aaron, with his youthful enthusiasm, would have one thing he wants to.
Do you want to give us your top 3 list?
Top 3.
Well, with my youthful enthusiasm and having just presented this study, I think one of the things might be that we're looking too categorically at post-thrombotic syndrome in the studies that have been performed thus far, and that, for example, looking more in detail at signs and symptoms and other parameters could have provided us more detail about the effects of certain treatments. So I think that is something for the future. If we see this low correlation of signs and symptoms, if we see that the signs are very strongly correlated with the presence of residual venous obstruction. We can imagine that certain preventive interventions targeted, for example, at residual venous obstruction might have more effect on one than the other. So I think for the future, one of the things that is an open question is we have to divide those two and report them separately in future studies to look separately at the signs and the symptoms. And yeah, number two for me would be other mechanisms than reflux and residual venous obstruction. As Arina mentioned, even in this high-risk population in the CAVA study with iliofemoral deep vein thrombosis and with these interventions, we for moderate severe post-thrombotic syndrome, we still see a substantial portion that does not have obstruction, that does not have reflux. So there have to be other mechanisms that explain this severe disease. And I think, for example, microvascular issues and the persistent inflammation could be perspectives that we study. And third, finally, for me personally, I enjoy reading about all the studies that have been performed in preclinical studies, in animal studies, where there's so many interesting insights into the mechanisms and the pathobiology. And I think that it is really time to make that translational step and really have a look if which mechanisms of these mechanisms that have been described are relevant in patients and if we can target them. So I think there is a bright future for post-thrombotic syndrome. I really enjoy seeing here and there preventional trials being started and await results. For example, I believe in Ottawa, they're doing a pilot with colchicine. We ourselves have done a pilot with Vinoriton, which is a flavonoid drug. So I think there's several options in the future, which hopefully will prevent some post-traumatic syndrome for patients.
Perfect, thank you. All right, and we have a question from Dr. Laura Villa. The question is, were females generally more symptomatic than males across all age groups? So maybe Dr. Iding, you can comment on that.
Well, across all age group, that's a good question. I'm not sure if going through the data I categorized by age group, so I'm a bit hesitant to say yes. At least overall, we did see that females were definitely more symptomatic, but whether this was in all age group or whether this was driven by, for example, a younger age, I'm not going to say yes or no because I'm not sure, but in the profile at least of younger females, we did see that these had the highest symptom load.
Perfect, thank you. Okay, and looks like let me just check one last time. Okay, yeah, no, that's it for questions. Okay, great. Well, I want to thank you both for participating and speaking with us with the CanVector National Seminars. So yes, thank you for attending, all our people who attended. Again, the recording will be available later on the CanVector website. You will get an evaluation by email about this webinar, and the next webinar is in May to be decided. Stay tuned for details. Thanks again, everyone.
Thank you very much, everyone. Bye-bye.